Hi, good morning, everybody, and welcome to today's virtual town hall discussion entitled Synergy Towards a People-Centered Health Agenda. My name is Paco Pangalangan. I am the Executive Director of Strat-Based ADRi Institute, and I'll be serving as the moderator for today's program. I'd like to thank everybody who's attended, and I'm excited to hear the discussion that is to come. To officially open today's program, let us first welcome the President of Strat-Based ADRi Institute, Professor Victor Dindo to deliver the opening remarks for today's virtual town hall discussion. Professor Manhit.
Ako, good morning.
Morning.
Good morning to our speakers in this virtual town hall discussion on synergy towards a people-centered health agenda. And I also would like to welcome our participants. I think as of this morning, we had a registration of nearly 250 individuals. Hopefully, we can bring them all in. As we like, part of our objective in the Strat-Based ADRi Institute is to bring stakeholders as we tackle and look into different issues, and in this case, a people-centered health agenda. Early on in the pandemic, I wrote in my regular commentary at the Philippine Daily Inquirer, I spoke of the healing power of collaboration. Because what we saw in the pandemic was it exposed the vulnerabilities and the intricacies of governance and the healthcare system in our country that we continue to face more than a year of this pandemic. But prior to this pandemic, we heralded approval in 2019 of the Universal Healthcare Act. But just like any laws that is important to key sectors of society, like healthcare, which continues to be a top personal concern of majority of Filipinos, based on our annual studies with Pulse Asia, one of our research partners. And what I see here is that the government should prioritize the implementation of the UHC law, together with other health laws, like the Cancer Act. But critical to any success of the execution of the law is the allocation of adequate resources. That's why early this year, through the initiative of some of my colleagues in the Institute, some of our partner civil society organizations, like the Citizens Watch with Orly Oxales, a columnist in the Manila Standard, and our colleague, Professor Louis Montimar of the Polytechnic University of the Philippines, the Bantay Consumer, partners in PAPU, Health Justice, and the Philippine Diabetes Society. When they came up with the idea of a universal healthcare watch, I told my colleague, the Institute will be very happy to continue to be part of it, to host different stakeholders. Because what we saw during this pandemic is something, again, that I wrote about after the first quarter of the pandemic. And it's something that we tracked. Last June, we had a study on top issues, concerns of the general public. And something that we noticed was that the economic consequences of this continuing health crisis is a topmost concern of the public. Mabigat para sa taong bayan. And the way forward, we believe, as if I'm writing it today, is to reform the country's healthcare system. Maybe through more funding in the Department of Health, strengthen social protection, and provide much needed enabling regulatory environment. I'm a professor of governance for 26 years before I focus on our institute. I always keep in mind, with so much resources comes the need for transparency and accountability measures. And when I see the staggering amount of 257.5 billion on the appropriations of 2022 realigned for COVID, the Bayanihan 1, the Bayanihan 2, and you hear all these investigations from independent senators. The more you demand, the more you desire for accountability. And as we hear debates, discussion in our own IATF, I believe when you look at our healthcare system today, we need adequate resources to constantly respond with the needs of the public. That's why the next slide, I wanted to emphasize the need of something that we have always advocated since the start of the pandemic. It's not whole of government, it's not whole of nation. It's about whole of society. And part of that whole of society is a need for a greater sense of accountability in the healthcare delivery system of our country. That's why when we were finalizing with my colleague Paco, hosting this virtual town hall discussion, I felt like writing it, speaking about it publicly, about the need for transparency and accountability in my commentary last September 14 in the business world. That we must demand complete visibility and reckoning of performance from our own public officials, especially those involved in COVID response, those involved in healthcare policy. We need responsive governance, responsive performance, and good governance. I said we don't need rhetorics. Words are not enough. What we need, as I welcome all of you this morning, is transparency and accountability from our public officials. But what we need as stakeholders this morning is how do we transform ourselves into a political force and push a healthcare agenda, a people-centered healthcare agenda, because we are entering an election season and we need to make our voices heard out. Again, good morning, welcome, and thank you for participating in this discussion this morning.
Thank you, Professor Manhit, for your remarks and for really laying the foundation for today's discussion on the need for a people-centered health agenda. I'm sure the discussion today will delve more into how important that is. But before we get to our speakers, I did want to just run our attendees through our program for this morning. We will be having first our speakers share some of their insights for about 10 minutes each, followed by our reactors who are all from patients groups to share their perspective on a responsive healthcare system for about 5 minutes each. And then after that, we're going to have a Q&A. For the Q&A, I really highly encourage our participants who have any questions to just send them to us through the chat or through the Q&A function of Zoom. And we'll be collecting these questions and trying to get through most of them or maybe some of them during our Q&A portion. And our goal here really is to end the program somewhere between 11 and 11:30. So that being said, I think the best thing to do now is just to move on and introduce our first speaker for this morning. Our first speaker will be talking about the current gaps in the healthcare system and proposed solutions. Dr. Lenny Hara is the Executive Director of the Council for Health and Development and one of the conveners of Shape Up Defeat COVID-19. She is one of the strongest advocates of evidence-based and people-centric pandemic response. Ladies and gentlemen, let us welcome Dr. Lenny Hara.
Thank you very much. Thank you, Professor Dindo. Thank you, Paco. Good morning, everyone. Okay, I will be discussing very briefly, I think in 3 parts, what is our health situation before the pandemic, what is it during the pandemic, and what do we think what does our group think about the healthcare system after the pandemic. May I share screen? Okay. So the Philippine society remains to be a backward agricultural country with no basic industries. Debt-driven, import-dependent, and export-oriented. So the health situation remains dismal, especially with the marginalized sectors. As we know, we are primarily an agricultural society, and it was covered. But look at our statistics. We have severe food insecurity as compared to other countries around us. We have 17.6% of our population who are not secure with regards to food. And we are urban-centric in development. Those green ones on the Philippine map would be where the health facilities are, and the red ones would be lacking in health facilities. So our hospitals are mostly 67% private and 33% public. And of course, we are already devolved. So we have quite a fragmented health system. With regards to the health budget, as was mentioned, we know that the health budget in billions from 2017 to 2020 has decreased, and the budget for PhilHealth has increased. If we talk about our health workers or those who are in the health sector, ideally, for example, the doctor to population ratio would be 1:100, one doctor to 1,000 population. But we have in 2020 one doctor to 32,000, more than 32,000 population. As for nurses and midwives, we cannot find the ideal ratio because this is not from WHO, but from other countries. One nurse to 500 population, but we have one nurse to more than 5,000 population. And for the midwives, we have one midwife to more than 5,000 population too. For dentists and for medical technologists and nutritionists, there's still lack of this health personnel. For example, for nutritionists, this is one of our problem, malnutrition. We have only one nutritionist for over almost 200,000 population, whereas the ideal would be one nutritionist to 50,000 population. So we really lack health workers locally, although we produce a lot of graduates, but we know that we are exporters of doctors and nurses. So here, our 10 leading causes of death, even before the pandemic, would be ischemic heart diseases, neoplasms, cerebrovascular diseases. Fourth is pneumonia. We have diabetes. So it's a mixture of non-communicable and communicable diseases. Before the pandemic, or just at the start of the pandemic, Dr. Tedros Adhanom Ghebreyesus, the WHO Director General, said, "We do not know what sort of damage this virus could do if it were to spread in a country with a weaker health system." So now we know the effect on us. And I don't think we have a very strong healthcare system. Currently, if you can see this, it will be the ranking of the cause of death, and it would be the same for on the average from 2015 to 2019, but it has increased in 2020. For ischemic heart disease, it's still number one. It has increased. The ones with the red arrows would be the increase in the cause of death. Second will be neoplasms or cancer. Third would be cerebrovascular diseases. The fourth would be diabetes mellitus. And there's no increase in pneumonia. That's the same because it was actually high also. The next one will be hypertensive diseases. That's number 6. And then we have COVID as the 7th during the pandemic. It's the cause of death, 7th cause of death. And so you can see here that many of the diseases which were ranked before also had increased number of deaths. Here there is no suicide, but according to the statistics, suicide has doubled during the pandemic. So next, please. This was the data yesterday, September 23, and we know that we still get very high positivity rate, 29%, despite our under-testing. And we have already, actually, it was shown that we are already on the 7th position as far as the number of cases of COVID is concerned. So, and we have reached over 2,400,000. Here it shows that most of our laboratories, our testing, because we have under testing, it's not accessible for everybody in the Philippines because most of it would be in the urban centers and in some provinces. So 116 testing centers are in Metro Manila, 18 in Cebu, and then in 10 other provinces we have it. But we still don't have testing centers in 31 provinces. So this is as of yesterday, a data as of yesterday. So it was admitted by our health secretary that, for example, the contact tracing that we do is still lacking. That's why there's a persistence in the community transmission of COVID-19. And although we have asked and demanded, for example, to have free mass testing, it was never done. And now we hear from the Senate hearing that about 500 million test kits have expired and were not used. So isn't that, I don't know, it's revolting for me. So we still have the lack of medicines, and we say that the capacity of our hospitals cannot hold the number of patients that need to be hospitalized at the moment. And the government sees the vaccines as the solution. It's not a holistic thing, but really even before we had the vaccine, President Duterte kept on saying, we will have the vaccine. But when the vaccine came, as of now, we still, if at the rate we are doing it, which is at around 374,000, more than 374,000 daily vaccination, whereas we need to have about 1 million of vaccination a day to be able to reach our herd immunity at 70% of the population, or 77 million Filipinos should be vaccinated. It will take us 9 months before we can reach the 70% population to be vaccinated. So if I could just summarize, we don't have mass testing. It's still we have under testing, and of course, contact tracing will not be possible without that much testing. And then we have insufficient treatment. Then vaccine rollout is quite slow. We have kind of militaristic and punitive approach too. We have seen tanks. Are these tanks? Yes, that was taken in Navotas, coming out, and then please, the other one, please. Yes, proceed. We have to compare this because this was taken in 47 days, in March 17 to May 2, 2020. Look at the number of people arrested during that day, or during those days. 158,000 people were arrested, whereas the ones vaccinated totaled 120,000. So there was a time when the arrests were more than the ones vaccinated. Oh, no, not vaccination, the swabbing, I'm sorry. So we say that it was quite a militaristic approach. What we did was to bring this out, the solutions for better normal based on the right to health. Dapat, lapat. Hindi puro lang lockdown. Ano yung lapat? Libreng testing at pagpapagamot sa COVID-19, agarang contact tracing at genomic surveillance, palawakin at pabilisin ang pagbabakuna, ayuda sa pag-quarantine at para sa lahat. At ang huli ay taasan ng kapasidad ng sistema pangkalusugan. So, a grounded, proactive, and enabling approach to the pandemic response and beyond is needed. We ask for a nationalization of health services, and then tax-funded healthcare over health insurance. And then we want a free National Public Health System Act, which will say an act providing for a free, comprehensive, and progressive national public healthcare system. And we hope that with this, we will be able to strengthen our healthcare system. Thank you very much.
Thank you, Dr. Hara. Thank you for sharing your insights on, of course, on the inefficiencies, the clear inefficiencies of the current healthcare system, and for offering solutions as well that can help address these gaps. So thank you po. Next up, our next speaker for this morning is Dr. Jaime Galvez-Tan, former Secretary of Health and a board member of Health Justice Philippines. Dr. Tan will be talking about the importance of setting a people-centered health agenda. As a former health secretary of the DOH and a member of Concerned Doctors and Citizens of the Philippines, Dr. Tan is here to represent Health Justice Philippines to provide his insights on the importance of making people the center of a national health agenda, especially in the middle of a pandemic. So Dr. Tan, the floor is yours.
A warm and pleasant good morning to all. Magandang umaga po sa inyong lahat. I'd really like to thank the Strat-based Albert Del Rosario Institute for Strategic and International Studies for inviting me to talk on the importance of setting a people-centered health agenda. What are the imperatives for this people-centered health agenda? First, I'd like to say it must be all of society, all of government and all of systems. It further means there must be some public-private partnerships with civil society organizations, community and people's organizations, and the academe, all sectors of society, government, and systems. And it is characterized by the following, democracy, respect, openness, participation, cooperation, equity, and tolerance. Next what are the essentials of when we say people-centered? For me, people-centered means focus on the community, particularly the far-flung rural areas, GIDA, the geographically isolated and disadvantaged areas of the Philippines, deep urban slums. I put as essential the bottom-up approach, definitely not really top-down. Movements have to come from the bottom using the primary healthcare, universal healthcare approach as well. No one left behind. And of course, the theme of health in the hands of the people, which I do have an ebook that you can download for free at my website, docjimmygalvestan.com. What is the priority or the contents of the health agenda priorities? Well, we know, of course, that the pandemic is here, and the pandemic has brought out all the various inefficiencies, inequalities, and run response to the point that we have neglected this 5 priority health agenda. Okay, number 1, non-communicable diseases. Why? Because our top leading causes of death and morbidities really are cardiovascular diseases, hypertension, diabetes, cancer, and even accidents. And these have been neglected almost totally, but yet they are the leading causes of death and dying, as well as diseases in the Philippines. I'd like to highlight this, but there are 4 issues in the agenda that has been bothering the Philippine health system for the last 30 years without any changes or continuing to rise. For example, teenage pregnancy. We are the only country in Asia with a rising, not even plateauing teenage pregnancy. We have to do something about this. Again, a great lament is the stunting of children below 12. Imagine 30% of all our children below 12 since 30 years ago up to now have remained stunted, not even a dent in lowering it, and it is always static there. Cohorts of children growing up to be adults which are unproductive, slow both in physical and mental well-being. This is not what we want. Tuberculosis, much as we launched so many national tuberculosis programs, the latest national tuberculosis prevalence study showed we went back to our 1995 situation of tuberculosis, which means we have not made a dent. There must be something wrong. Before we were only in the top 20 countries, now we're in the top 5 in the whole world. And lastly, HIV/AIDS. While still considered small, but still we are the only country in the world, in the whole world. We are the only country that has HIV/AIDS continuing to go up, and up again. Not even plateauing, not even going down. We have to learn. All countries of the world have already contained HIV/AIDS. How come the Philippines cannot even control it for the past 14 years that it is on the rise? Ladies and gentlemen, of course, the most essential part and the most important of all in coming out with a people-centered health agenda We need inspirational leadership, national as well as local government leadership, with responsive action, transparent and accountable governance. Maraming salamat po. Thank you very much. To God be the glory. Thank you.
All right. So thank you, Dr. Tan, for that. That was a great presentation on the need for a people-centered health agenda. With that, we now go on to our third speaker for the day, for the panel. I do apologize if there's some background noise over here, but hopefully you don't hear it. Anyway, coming back to the program, our next speaker is Ms. Marie Fatima Grilli Garcia Lorenzo, the president of the Philippine Alliance of Patients Organizations, or PAPO. As a president of PAPO and one of the lead conveners of UHC Watch, Ms. Grilli Lorenzo is here to provide profound insight on what is universal health care and how patients and patient groups can lead in shaping the country's next healthcare agenda. Ma'am Grilli, are you, the floor is yours po.
Thank you. Thank you very much. Good morning, everyone. The Philippine Alliance of Patient Organizations is a coalition of patient organizations advocating for universal access to healthcare and allied services, and is a member of the International Alliance of Patient Organizations. We aim to empower Filipino patients, including persons with disabilities, through education, networking, policy advocacy, and capacity building. PAPO hopes the following will be included in the next healthcare agenda. First, for the Department of Health to have stronger institutional accountability and be more responsive to the health priority needs of the community. This means DOH needs to be true to its mission of continually moving towards universal health access and quality care. This also means that the DOH as an institution must be aware of the inequities and must continuously improve itself toward overcoming them to provide more care for the least. At the same time, it needs to be more responsive to the shifting health priorities. Second, the DOH needs to have a strategic perspective and plan that look at longer-term health system development. Third, it needs to promote primary health, health seeking, and health values to the community to sustain co-ownership of health. Fourth, the Department of Health needs to have good leadership that can cope with the highly adaptive demands of our country. These demands stem from lack of resources and distrust in the health system. Finally, DOH needs to be supported by strong policies that are well protected from political influence. Patient groups have a key role in helping the institution become accountable and responsive to the patient needs. PAPO continuously works with DOH and PhilHealth to provide critical feedback in expanding the frontiers of the health system. We also collaborate to join in programs that help expand universal health. PAPO has been supportive of the DOH vaccine campaign through our Bakuna Now Na social media campaign and infodemic and vaccine hesitancy webinars. We have also engaged the Health Technology Assessment Council to increase our capacity, and we are now guiding patient groups on how to submit their topic nomination forms to the council. We have been part of the universal health discussions from the onset. We take time to study and understand the technical aspects of this law and work with both DOH and PhilHealth in providing important practical, and workable solutions that benefit patients. Aside from the universal healthcare, patient leaders are also members of a number of technical working groups at the Department of Health, such as the NICA Strategic Plan, National and Hospice Care Program, Patient Safety, Health Facilities, and Advisory Council on the implementation of the Cheap Medicines Act. The leaders we have worked with appreciate our generative approach in providing feedback. These are generative engagements and feedback because we are conscious of providing actionable plans to policymakers. This generative perspective is very important in contributing to the health system sustainability. We still need to strengthen patient engagement in the health system, and this could be realized if patient leaders and groups are empowered. This means there must be policies that safeguard their participation in shaping the health system. Second, patient groups also need capacity building. Not all can engage government with a critical yet generative perspective. Many are still unfamiliar with the system. It will also help if the public health institution dedicate resources to consistently build the patient group's capacity. DOH needs to improve systems and scorecards to include patient feedback. This deepens the institutional accountability and greatly improves the health system. It would also help to have patient organizations be recognized at the provincial and even municipal levels. At this level, health system implementers can improve service delivery and become a lot more responsive. It will also enable patient groups to be part of the primary health and preventive health response. Lastly, and more importantly, patients should be critical and vote leaders who have integrity and practice good governance. We have all seen and felt the effect of our leaders' poor decisions on our health system. Let us not commit the same mistake. Be critical and choose our leaders wisely. Thank you.
Thank you, Ma'am Gurley. That's a very good ending note that you provided all of us, and it's something I think we should keep in mind. So thank you very much, po. Next up, our next panelist naman po, if I may. Thank you, Ma'am Gurley. Our next panelist is Dr. Beaver Tamesis. He is who's here representing none other than PHAP, the Pharmaceutical Health and Healthcare Association of the Philippines. Dr. Tamesis, as its president, will be discussing the crucial role of pharmaceutical industry plays in addressing the current crisis and how this industry can also be a part of a more resilient and people-centered health agenda. So Dr. Beaver, the floor is yours.
Thank you very much for the invitation, Paco, and Orly, the Universal Healthcare Watch, and the Alberto Del Rosario Institute for the kind invitation to speak today. Let me just share my deck. I promise that I'll go through the contents quickly since a lot has already been covered earlier by our speakers. If I can get this to work. Okay. How do I make? Can you see my screen?
Yes, we can, po. It says engaging pharma towards an inclusive healthcare system.
Sige. So, okay, so let's get going. I guess the things that I'd like to really focus on is really what has the pandemic taught us and what has been the role of pharma in this particular endeavor or the things that we're dealing with today. Again, let me introduce PHAP. We are the innovator group of companies, research-based. So we do a lot of the research and the development of new, hopefully new compounds that can address the needs of humans, our humans society today. Now, never let a good crisis go to waste. What else can I say about our
Sir?
former prime minister?
Sorry po. I think are you on slide 3? Because we're still on slide 1.
Okay, so I think what happened there?
Parang nag-freeze yata po.
Nag-freeze.
Yeah.
Okay, that's
Oh, there.
unfortunate.
What's this? We can see.
Never let. Are you seeing? Oh, are
It's a
you
bit.
seeing?
It's a bit different. Medyo ibang view po siya, no? But at least now we can see the never let a good crisis go to waste slide.
Okay, so
Different view, but much better than earlier. Sorry about that po.
yeah,
Okay.
Dr. Bat nagluloko. Okay, so
Yeah, we can see your notes po pag ganito.
yeah, well, no notes naman to.
Okay,
So,
po.
sige. So, yeah, so this basically this is the agenda. First and foremost, what we are bringing to the game, the treatment and vaccines updates, and a bit of commentary on the pharmaceutical academic regulatory responses. Okay, the situation there of COVID. You see the slide, I hope. I think we've already heard a bit about the Philippine situation, but basically it's pretty grim, right? More than 2.26 million cases in the Philippines. It's really a global epidemic affecting 192 countries. Yet, in response to this, in a matter of less than 18 months, really, vaccines have come to the fore and are going to exceed 12 billion doses in production before the year is out. And that's a fantastic achievement if you think about it, because vaccines traditionally take a long time to develop. Yet, we always show you this slide. Yet, how did we manage to bring vaccines so soon into the marketplace? It's because we don't focus on this area, the kind of research that has been going on for decades prior to this. I mean, like nobody can predict when exactly the pandemic was happening, but people already anticipated that we need to understand the coronavirus much earlier. And different platforms of the different types of vaccines were already being developed during this particular time. And which is why the basic research has been going on for over 10 years. And now we have the star of the show, the messenger RNA viruses, which is the most popular vaccine being now used in the US and a lot in Europe also. So what has been the impact? I have US data. You can see when the vaccines were rolled out, immediately there was a huge drop in the number of cases. However, with the Delta surge, we have this resurgence, particularly in the unvaccinated. So it's now become a pandemic of the unvaccinated. And all of this, these vaccines have really not been just resting on one particular company's luck or research to deliver, but really a host of collaborations across the board. All right, all these companies have been working with each other to try to find a solution. But hey, because hey, companies are made of people, and we also get sick, right? So it's really important that we protect everybody to get everybody safe. That's the only way to move forward out of this. And as we studied and understood this particular virus and the disease better, it became pretty clear that there were actually two phases that we need to deal with. The viral replication phase, when the virus first infects a person, and then the immune phase, the overactive immune phase that actually kills patients. This is the phase that kills people. So vaccines address this portion, early treatments focused here, but now we have to start thinking, can we get here? And that's what precisely this particular slide demonstrates. Early on, the focus was really on the severe or critically ill patients, how to get them, keep them alive. I'm sorry about that. But now more and more research is starting to go into the earlier phases of the disease, including one of the drugs that my company is developing, molnupiravir, which I can talk about a little bit here, because right now we're actually in the phase, we're actually approaching potential entry now into different countries to be able to hopefully reduce hospitalization. And voluntary licensing deals have been signed, which actually now brings the product or the drug to more people, greater access, less expense. So Yes, companies do have that responsibility. It's not just us. Remdesivir is being marketed by Gilead through voluntary license companies just to be able to bring down the price. I remember about a year and a half ago, the price of remdesivir was something like 120,000 pesos for a full course of 5 days. Today, it can be had for 6,000 pesos. Competition works. Voluntary licensing does work. Work with us on this. I think that's the message here. And there are other multiple treatments that are quickly being studied by pharma. And some of the green ones have already really gotten into the mainstream of treatments, and the yellow ones are still being studied, or at least final trials are hopefully going to come very, very soon. The other thing that we've really recognized is really the important critical nature of the role of data and the data scientists who provide the analysis and understanding of what all of this data means. Really, I mean, like, there have been forecasting on a weekly basis. We're seeing the trending coming down. So really, we need to centralize this data. We need people to have quality data coming through so that we can better get results, or at least have informed analyses. Despite all of that, the evidence that data is required, we still have crazy behavior such as price controls, because it flies in the face of all the data showing that really generics really control the markets in terms of counting units or tablets or boxes, versus the innovator companies, which really are just a very fixed level for the last 8 years in terms of actual movement or dominance in the market. It's really all generics. Now, so which is why we're saying price controls really aren't the solution. They are not the solution. Generics are already widely adopted, as I showed you earlier, and you have this broad range of prices for the different types of molecules that are available. Price controls really just cause distortions in the marketplace. There are many, many ways the government can actually help continue to bring down pricing, simply because they just need to work at it. They just need to work, and we just need to negotiate on these. India and Canada have seen that price regulations actually result in shortages. So really, it's not the way to move forward. The other thing that also galls us is really, here we are in a crisis where there are so many effective medical treatments, yet scheduling for HTA analysis has been pushed back all the way to March 2022. And this is impacting drugs that actually save lives or prolong life, good quality of life, be it in oncology or other illnesses. And this is something that obviously patients are constantly worried about. We had to try to address these fears during this pandemic to try to bring patients back to seeing their doctors to get their therapies. Now, aside from that, we're also seeing constantly this delay in translating research into clinical action. Can take up to 17 years from approval and publication to final adoption of these particular new treatments. Because that really we have to deal with practice inertia, the need to develop consensus, information overload. People are unable to filter what's going on, really. And then burnout to those tasks to implement these new changes. So it is really behooving upon us that we have to have greater interaction with physicians. Yet this pandemic has been very, very challenging, has made face-to-face really not something that people engage in now. But at the same time, by moving to digital, there's greater transparency of these interactions in the digital space. And we all have guidelines on how we can work closely with the physician medical community to ensure that these new innovations and the benefits that patients can get are translated into clinical action. Now, with the government, regulators, academia, I mean, like, this pandemic has really shown us the value of collaboration. It's been unprecedented. Governments actively supporting development of these vaccines, the appetite of the regulatory agencies to go through the processes very much faster with greater speed and urgency, sharing across different companies of trade secrets. We're actually sharing trade secrets just so that we can help in accelerating manufacturing and to improve access and distribution. With that kind of environment, hopefully we can bring in more of these companies that actually have innovative treatments, such as Lilly, such as Moderna. one thing that you'll see is that none of these companies are in the country. None of them are in the country. Right? We don't have that environment, unfortunately, for now. So really what we're trying to say here is that if we really want to bring the pharma and really engage closely with the society and the country's needs, there may be the need for fiscal support and incentives. But more importantly, is really regulatory agility and flexibility and a collaborative IP environment to ensure that we can focus on things that actually do work, such as voluntary licensing without royalties. These are things that companies are ready and willing to engage in, particularly in this time of pandemic. But we need everybody to really appreciate research and development, establish policies that foster innovation, predictable environment, regulatory reforms that can bring novel treatments to patients faster, and enable appropriate access and reflect the full societal value of novel anti-cancer agents, anti-infectives, vaccines, antivirals. So with that, thank you very much for giving us this opportunity to speak. We'll be glad to take questions later.
Yes, thank you, Dr. Beaver. You know, I am no health expert, but I do agree very much with the need for that. What did you say? Was it a predictable environment that fosters and cultivates innovation? Indeed, very much, especially now during this pandemic. So Dr. Tomesis, thank you so much. And we'll now move on to our next speaker. And we have none other than Dr. Jaime Almora, the president of the Philippine Hospital Association. So to complete this forum's round of speakers, Dr. Almora, who is the current president of the Philippine Hospital Association, is here to share some insights on the current challenges of the healthcare providers, such as himself, face in this time of pandemic and in the implementation of the universal healthcare system, as well as the role of hospitals in building a people-centered health agenda. Dr. Almora, good morning.
Good morning.
Good morning, po. The floor is yours.
Can you see my slide?
We can, po. Challenges.
Okay. My topic is about the challenges and the threats in the implementation of the universal healthcare law to the healthcare provider and the healthcare delivery as a whole. The mission of the universal healthcare law is the healthcare law is a healthcare model that provides all Filipinos better access to the comprehensive set of quality and cost-effective, promotive, preventive, curative, rehabilitative, and palliative health services without causing financial hardship and prioritizes the needs of the population who cannot afford such services. Okay, the vision is for better health outcomes for all Filipinos. This is a noble, laudable, and lofty aspiration of our government for our people. And the Philippine Hospital Association supports this endeavor. And we are here willing to support and to participate in the provision of the necessary health services to the people. And more than that, we are here willing to provide the initial financing or the credit line to PhilHealth in order to realize this lofty endeavor. However, we do recognize many challenges that will threaten the very survival of the healthcare providers and may threaten the survival of the healthcare delivery system that the universal healthcare law envisions. I have here few of the challenges, and I may not be able to finish all of them because I am given 10 minutes to finish this, but I will try my best. The first is the ambitious and the ambiguous provisions of the universal healthcare law. The second is the confiscatory provision of the Universal Healthcare Law. Third is the unrealistic expectation of the service delivery network. Fourth is the full financial risk protection for hospitals. And five is the lack of due process in quasi-judicial proceedings and accreditation committee. First, on the ambitious and ambiguous provisions of the Universal Healthcare Law. Section 5.1 provides that every Filipino citizen shall be automatically included in the National Health Insurance Program. This is good because if we are going to succeed in this, we would be better off than the Obamacare of the United States and be at par with the more economically advanced countries who have a socialist healthcare delivery system. Section 9.2 provides that PhilHealth identification card shall not be required in the availment of any health services. This is just an expression of the government of their confidence that of its capacity to provide for all Filipinos, and its confidence that the Filipinos are not going to abuse or overuse the program. In Section 9.2, it provides that failure to pay premiums shall not prevent the enjoyment of any program benefit. Again, this is an expression that the government can indeed can pay and have the money to pay for the healthcare delivery, and that the people are not going to abuse or misuse this program. But are they? So in Section 9.2A and 9.2B, it provides a plug for the possible abuse and misuse of the program and the non-payment of premiums. It states that the employers and self-employed direct contributors shall be required to pay all missed contributions with an interest compounded monthly of at least 3% and not exceeding 1.5% for the self-earning, the professional practitioner, and the migrant workers. This absolute right is given to our people to health care. And they are promised that all they have to do is go to the hospital anytime, and they would be provided services. So with the increase in the premium of PhilHealth, many are wondering why are patients or people going to pay for services that they can get it for free. They have absolute right. And we know from past experience that absolute right corrupts absolutely. And in our business transactions, in our day-to-day encounter and engagement with people, we are often warned that if the offer is too good to be true, then it may not be true. An example is a letter received from a regional PhilHealth office to a hospital about 11 months after the implementation of the Universal Healthcare Law, which was November 22, 2019. In the letter, the regional PhilHealth office was asking the hospital, why is it that in the mandatory monthly hospital report, there are patients that are not given PhilHealth privileges, and they want the hospital to explain. So the hospital responded after a week, and they said that it is because of the presence of policies like the violations of single period of confinement policy, wherein a patient who gets sick of the same illness within 90 days is not qualified to receive PhilHealth benefit. Also, there are policies that those who are admitted and stayed in the hospital for less than 24 hours, they are not qualified to receive PhilHealth benefit. And also, those patients that have exceeded the 45-day benefit limit for PhilHealth are not also given privileges. So that letter was sent to the regional office, and after that, an advisory was released by that regional office stating that they are going to enforce those policies. Number one is the 45-day benefit allowance for each year, meaning if you get sick more than 45 days, you cannot be given PhilHealth benefits anymore. The single period of confinement, meaning if you get sick of the same illness within 90 days, meaning if you have an abdominal, if you have a hyperacidity and abdominal pain, and you have another abdominal pain with the same diagnosis within 90 days, you're not qualified anymore for the PhilHealth benefit. And also for the dialysis patient, those who are on treatment more than 90 days will not be qualified. There are 144 treatments for each patient for a year. So PhilHealth is going to pay only for 90 days. So that is in violation of the intent and purposes of the Universal Healthcare Law, which promises that if you are sick, all you have to go is to go to the hospital and you will get the PhilHealth benefits. The second challenge is the confiscatory provision of the Universal Healthcare Law, implementing rules and regulations to private hospitals. There is that no co-payment provision for those in basic accommodation or those in ward accommodation. It is mandated that private hospitals should have not less than 10% of the authorized bed capacity as ward. And in those wards, there will be no balance billing or there is no co-payment. For the government hospital, it is mandated that we will have 90%. And for the specialty government hospital, they will reserve 70%. In Section 9.4, it states that no other fees or expenses, including professional fees, shall be charged to all members admitted in a basic or ward accommodation. This is a promise given by the government and did not specify whether this is only for the government hospitals or even in the private hospitals. In Section 9.6, provides that in the absence of available beds and transfer to another facility, it is not, and transfer to other facility is not feasible. Members who opt for basic or ward accommodation but admitted in non-basic accommodation shall be entitled to no co-payment. So if you are a patient admitted in the private room or in the suite room, and you heard that there are patients in the ward who will not be charged any co-payment from the excess of the case rate, and all you have to do is to manifest that you want those privileges, even if the ward is full already, then you are still entitled for the no balance billing or the no copay, even if you are in the suite room. In Section 9.7, it states that in the event of change in level of care, members who opt for basic or ward accommodation shall be considered as such. Meaning if you are in the private room and you are going to be transferred to the intensive care unit, you can manifest that you want to be admitted in the basic accommodation and you will be considered as such, meaning you are not going to be charged for the extra cost of being in the intensive care unit. And also, even if you will need additional diagnostic or life support facilities and services, you will not be charged for those additional services if you manifest that you want basic accommodation, even if you are in the private room or suite room. So therefore, these provisions render moot in academic the provision of 10% limit for no copay. The law provides that the limit for 10% in private hospitals. So theoretically, all patients in the private hospital can avail of no copayment. What does the law say? The law says that co-payments and co-insurance for amenities in public hospitals shall be regulated by the DOH and PhilHealth. So what I mentioned a while ago is the IRR. This is the law itself. And in Section 9, what is going to be regulated only is our public hospital. Nowhere did it say that they are going to regulate the copay in the private hospital. But when they made the IRR, they have overreached and overextended the intent and purpose of Section 9 and provided those provisions that will theoretically give privilege to all patients for a no copay in the private hospitals. So the position of the PHA is that this provision of no copayment and fixed copayment is unlawful if applied to private hospitals. It has the effect of confiscation of private property if medicine supplies and services in excess of case rate and the fixed co-payment are mandated to be given to patients without payment. Confiscation of private property, supplies, and medicines would result to the hospital taking losses, and they take losses, they would fail to improve the hospital and to provide the necessary services, quality services. Number 3 is the unrealistic expectation for service provider network. Section 18 of the law states that PhilHealth shall endeavor to contract public, private, or mixed healthcare provider networks for the delivery of individual-based health services. Section 6.5 provides that primary care providers shall act as the navigator, initial continuing point of contact in healthcare delivery systems, except in emergency. In Section 6.6, every Filipino shall register with a public or private primary care provider of choice and with the consideration of proximity to the patient. This is the model of the Universal Healthcare Law. This is the process. All patients must register to a primary care provider. The primary care provider will be the one to decide and navigate. We provide the initial management. For the amount of 500 pesos per year per patient, it will provide the consultation, the basic diagnostic examination, and some medicine. And in private primary care provider, the PhilHealth is going to pay 750 pesos per patient per year with a copay of 500 pesos. That makes it about 1,250 pesos for a year for a patient. That is even less than what a mechanic would charge for just lifting the hood of a car to look at the problem of the car, and without doing anything yet. And so the primary care provider will refer this patient, if necessary, to the specialists who would manage the patients, and if necessary, will refer the patient to the different hospitals, the level 1, the level 2, or level 3 hospital. The level 3 hospital would be considered the apex hospital, and patients can go directly without going to the primary care provider to the level 3 hospitals. That is to me is unrealistic, because it presupposes that the patient does not know what his illness is, and he does not know where to go for a better care, and he cannot search for knowledge of his disease. A more realistic provision would be the patients going to primary care provider if they do not know where else to go, but having the right to choose, and these patients are intelligent, and they know what is good for them, or they know what is necessary to address their illness. So if they have a breast mass, they would go to a surgeon. If they have a pregnant and they need prenatal care, they will go to an obstetrician. If they have a baby, they will go to a pediatrician, rather than going to the primary care provider, spending time and probably wasting time and money. So the specialist would then refer them to the level 1, level 2, or level 3 hospital. But this realistic view is not what is provided in the Universal Healthcare Law. You have to go to the primary care provider first. Now, the PHC position is that decision of patients to bypass the system must not result to denial of payment of claims, because what we are most concerned about is that if the patient would violate and go directly to the specialist, PhilHealth will not pay that specialist, or they go directly to the hospital, the PhilHealth will not pay this hospital, because there is a violation in the process flow. Now, number 4, I don't know if I still have the time. I may be running out of time, so I'll just go fast. Number 4 is the for financial risk protection for hospitals. The implementation of the Universal Healthcare Law is at best experimental and exploratory due to the presence of plenty of loose ends. And there is no guarantee of payment to hospitals for the expected errors and miscalculations leading to possible financial crisis. Hospitals are mandated by law to provide services to patients and extend credit to PhilHealth despite arbitrary or untenable policies. An example is the non-payment of COVID claims due to internal problems in PhilHealth, which we are suffering at present. many of our claims were not paid since the start of the pandemic. You could just be bewildered how the hospitals are able to survive without being paid for their COVID claims. But this is because there are policies that are unsustainable, and there are internal problems in PhilHealth. And because of these policies and internal problems, the hospitals, the healthcare providers are the ones suffering. And if the healthcare providers suffer, the patients also suffer. And this is what is the situation that we are right in now. PhilHealth creates policies to regulate availment according to its actuarial. It is dictated by how much money they have and not according to law. The PHC position is that PhilHealth must pay hospitals for cost of services given to patients in the absence of clear guidelines or presence of confusing policies or due to arbitrary rulings. And there is also lack of judicial process, due process in the quasi-judicial proceedings or the procedures rules on administrative cases as provided by law in the PhilHealth law. And there is also problem in the accreditation, appeals, and review committee processes. This is about accreditation of hospitals. In the amendment of the procedures and rules on administrative cases, it authorizes the PhilHealth Regional Office to issue preventive suspension or deny accreditation to healthcare institutions while pending investigation of administrative cases or loss of integrity or for reason of previous violation, even without conviction. The sacred principle of due process is sacrificed in favor of expediency. The PHA position is all administrative cases must go through proper adjudication with full observance of due process, and that the PhilHealth Circular 2020-003, allowing area vice presidents in the PhilHealth regional offices to deny accreditation due to an ongoing administrative case or a past administrative cases be revoked. We have reasons to object preventive suspension because there is no limit or metrics to what violation is punishable by death. Denial of accreditation to a hospital is similar to a death sentence to person.
Hey, Dr. Amora, you think?
Yes.
Sorry po. Maybe 1 minute to wrap up.
Okay.
Kaya po ba?
I will wrap up.
Thanks, Bob.
My presentation. I will go to my last slide. So the success of the universal healthcare law is possible only if there is a fair and impartial implementation and the financial risk protection for patients. And there is financial risk protection for patients and hospitals alike. It's not only financial risk protection patients, but also the hospital, because you cannot separate one from the other. And a win-win engagement for all parties. There will be absence of corruption. There is adherence to due process and the principles of administration of justice. There is healthy respect to private enterprise and its right to engage in gainful activity as a guarantee for progress. And we believe in the healthcare truism that what is good for hospitals is good for patients. What is detrimental to the health of hospitals, it is detrimental to health of the patient. So therefore, to provide people-centered healthcare, we also have to think of the viability and health of the healthcare provider. Thank you. That ends my presentation. Thank you so much.
Thank you, Dr. Almora. Sorry again if I had to jump in there. I know that there are so many challenges indeed facing, the implementation of the universal healthcare law. And if there's one thing that has been clear throughout all of the speakers, it's that, in the immortal words of Zac Efron, we're all in this together when it comes to public health. And with that, and I do hope that these challenges that you've all raised can be addressed with a people-centered public health agenda. I'm sorry, a people-centered health agenda. And with that, I'd like now to thank all of our speakers and now move on to the second part of our program, which is a panel of reactors. We have gathered representatives of various patient groups in the Philippines today to react to the points raised by our speakers and share their input on how the healthcare system through the country's next healthcare agenda be more responsive to the needs of the groups they represent, and of course, to the Filipino people at large. Our first reactor, and may I emphasize that we are trying to keep it to 5 minutes per reaction, if possible po, no? is Miss Eileen Antolin, the Vice President of Philippine Foundation for Breast Care, Inc., or otherwise known as Casuso Foundation. Miss Antolin, the floor is yours.
Hi.
Thank you for being here.
Thank you, Paco.
Thank you po.
Thank you for the invitation po. Maraming salamat po sa pagkakataon na maisaboses namin ang panig ng mga pasyente. I'll be talking in Tagalog because mas mare-represent ko po ang tinig ng mga pasyente sa ganitong paraan. Totoo po na nakakatuwa po na makita ang iba't ibang bahagi ng healthcare delivery system natin at maunawaan ang kabuuan ng ito kung paano magtutulungan ang bawat sektor para mabuo ang ating healthcare delivery system. Agree po ako sa sinabi ni Dr. Jimmy Galvez na kailangan po ng people-centered health agenda where we need inspirational leadership, responsive action, and transparency and accountable governance. Simple lang po ang sasabihin ng mga pasyente. Bilang ako po ay kumakatawan sa mga kababaihan na may breast cancer, simple lang po ang naiisip ng mga pasyenteng kagaya nila. Pag may bukol, pupunta sa ospital, magpapa-check up, magpapagamot. Hindi na po abot ng kaisipan ng isang ordinaryong pasyente kung ano ang kinapapaloob ng universal healthcare system, ano ang mga treatment na kailangan nila dahil maniniwala po sila sa kung ano lang ang ibibigay ng kanilang mga doktor. Ngayon, bilang kumakatawan po sa mga pasyente, maganda po na napag-uusapan natin itong mga pulisiya na kailangan nila upang maproteksyonan ang kanilang karapatan sa kalusugan. Pero ito po yung gap na nakikita namin. Hindi po sapat ang kaalaman ng pasyenteng Pilipino kung ano ang dapat niyang matanggap bilang isang pasyente, kung anong klase ng treatment ang ibibigay sa kanya, kung ano po ang dapat na trato sa kanya kapag siya ay pumasok sa isang public health system. Kami po bilang kinatawan ang kailangang magkaroon ng sapat na kaalaman para ma-educate sila at masabi na ito yung dapat na ipaglaban ninyo, ito yung dapat na karapatan ninyo. Ang nakikita po naming kakulangan ay yung pong babalik at babalik pa rin po tayo sa napakaraming magagandang mga pulisiyang nagawa natin. Babalik at babalik po tayo sa na-educate ba natin ang mga pasyente kung ano ang dapat nilang ipaglaban. At sa paggawa po ng pulisiya, narinig po ba ng tama ng mga gumagawa ng pulisiya ang tinig ng mga pasyente nung ginagawa nila ang pulisiyang ito? Kasama po ba sila? Oo, bilang isang representative ng patient organization. Pero karamihan po, ang katotohanan po ay karamihan po ng umupo sa mesang yun ay mga nagrepresent lamang sa boses ng mga pasyente. Meron po ba talagang boses ng pasyente na naupo at naipaunawa yung mga pulisiyang ginawa? Na ang bottom line ay proteksyonan ang kanilang karapatan. Ito po yung nakikita ko pong gap. Maganda po ang mga pulisiya on paper. Pero pagdating po sa pagpapatupad ng mga pulisiya, alam po ng mga pasyente na ang dami sa kanilang mga karapatan ang hindi po na ipaglalaban. Classic case na lang po. Alam po namin sa mga pasyente namin na kapag po sila ay lumapit sa kanilang mga doktor, ang prescription po na gagawin sa kanila ng doktor ay base sa kanilang financial capability. Hindi po sa kung ano ang nararapat na gamot para sa kanila. Kahit po sabihin na ang sinasabing gamot ay pinaka-epektibong gamot para sa breast cancer, alam po ng mga pasyente namin na hindi nila yon matatanggap. Dahil nalilimitahan po sila ng kung ano ang pulisiyang na-create. For example, ng Breast Care Medicine Access Program, na nilikha po na one size fits all. Alam naman po natin na iba-iba po ang kaso ng pasyenteng may breast cancer. Depende po iyon sa kung anong staging, kung ano po ang kanilang pre-existing conditions, kung ano po ang responses nila sa nauna pang mga gamot na naibigay sa kanila. So, mahirap po na ipaglaban ng isang pasyente na ito dapat ang akin, ito dapat ang natatanggap ko ngayon dahil alam po nila na nalilimitahan sila ng kung ano lang po ang programang nandoon sa public healthcare system na available para sa kanila. Sa aganang amin po, sana po totoo na ang healthcare delivery system natin ay inclusive and accessible to everyone. It doesn't matter po kung mahirap o mayaman dahil madalas po sa pakwentong paraan, sasabihin ko po sa inyo na ang aming mga pasyenteng tinutulungan kapag nahalo po sa mga pasyente na may pareho nilang sakit at marinig nila ang testimony ng isang sikat na artista na lumaban sa breast cancer at nagtagumpay, masasabi po nilang hindi yata ako anak ng Diyos dahil iba po yung treatment na natanggap nila at iba po ang treatment na natanggap ko. At ako po ay kasalukuyang nahihirapan dahil hindi ko naranasan yung naranasan ng isang pasyenteng nasa isang pribadong inaalagaan ng isang pribadong doktor. So, yun po bilang kumakatawan sa mga pasyenteng mahihirap na nakikinabang sa public healthcare delivery system, sana po marinig po ang tinig ng totoong pasyente na sumasailalim sa totoong sitwasyon sa isang public healthcare system. Maraming salamat po sa pagkakataon na maisatinig po ang sa loobin ng mga pasyente nito.
Okay, thank you so much, Ms. Antolin. We very much appreciate po yung share niyo po sentiments of your group and of the reality on the ground, the painful reality on the ground. So next up naman po, we have our next reactor is Ms. Cynthia Madaraog, who is the president of the Philippine Society of Orphan Disorders. As a longtime advocate, she is here to share insights on today's presentations and how the healthcare system can support better access to treatment and innovations for rare diseases. Hi, Ms. Madaraog.
Hi, good morning, everyone. And first of all, I'd like to thank you for this opportunity. It is very seldom that our sector is represented and is heard by the various participants to give them proper health care. Just a brief description of our advocacy. We take care of people with a genetic heritable rare disease. We have a law, the Rare Disease Act 10747, passed in 2016 with the implementing rules and regulation after a year. It's been 5 years and we have been addressing Department of Health to implement the law and also PhilHealth. But the process of getting the decision of the Department of Health to accept these certain rare diseases for funding will take a long time. It may not even be in the lifetime of the patients. I'll give you an example. First, I understand that the Department of Health requires administrative orders, strategic planning, public consultation. At the same time, now we have the HTA, which will take care, which will require about 2.5 years to process the approval of the HTA. People with rare disease are, most of them, if they are part of the newborn screening, in 48 hours, you can detect if they have a rare disease. But some, depending on the gravity when they are born, can die immediately or even a few months or even a few years. Some of them, not all of these 24 rare diseases detected by the National Born Screening have treatment. Okay? So if it takes 2.5 years for HTA to approve the funding, most of those that are detected by the newborn screening may not live to be treated for free because the cost is very expensive. The cost of a milk for maple syrup urine disease for an infant newborn is 2,500, requiring 3 cans a week. And most of our patients' annual family income is only 25,000 a month. We have also another group, which is the metabolic lysosomal storage disease. And thank you for a pharmaceutical company, which I can't name at the moment. They have been able to give compassionate use because the cost of the medicine is about 80,000 on the average per vial, depending on the weight. So if the child is 25 kilos or 50 kilos, it can even run to 1 million for every infusion, and they require 2 infusions. So our concern today, and I would like to bring up to you, how realistic is universal health care to be implemented for rare diseases? We have been losing a lot of patients who could not wait for the treatment. In our roster, we have 66 types of rare diseases out of 6,000 to 7,000 worldwide rare diseases, and 350 patients with various rare diseases among the 66 types of rare disease. I think with the Universal Healthcare Law and the Rare Disease Act, where funding will come from Syntax, will still not be available in the near future. So I don't know how we can hasten this to be able to save lives or improve their quality of life for so long as they can live. These are my reactions to some of today's topic on universal healthcare and patient-centered. Can't hear you.
Oh, thank you. Thank you po. I was on mute.
Yes.
But I was thanking you po for sharing your insights. I very much appreciated po. So with that po, I'd like to move on na rin po and give our next reactor an opportunity to share as well. So thank you, Ms. Madaraog. Our next speaker is Ms. Cynthia Clement Dunce. She is the board member and vice president of the Philippine Diabetes Support and Awareness Group, Inc. As part of a patient organization and also a member of UHC Watch, Ms. Dunce will share her thoughts on the presentations of the speakers and her insights as well on how to improve access to healthcare services, most especially to those with diabetes. So, Ma'am Dunce, the floor is yours.
Hi, good afternoon, everyone. Thank you very much for inviting me. And most of the topics that I will discuss are actually are in place already, but we have a problem in the implementation. Yeah, for example, DOH is distributing free medicine, free maintenance medicine, but it doesn't reach the provinces or far-flung areas in the country. And now we are ending up of hundreds of thousands medicine that are expired in the warehouse. It's not only the COVID testing are being left expired in their warehouse. So it's the logistics that is having a problem. We need a better distribution system for the country. Number two is we have the DOH have this list of maintenance medicine, not only for diabetes, which has what they call a maximum retail price. And I noticed that the insulin glargine, which is the most common insulin that is given to diabetics, type 2 diabetics, which is about 90% of diabetics, are not included. So a lot of our members are having problems in their maintenance because of the prices. And number three, uh, there is also a project that is called Insulin Access Program. But a lot of our members are also complaining that the accredited hospitals that can sell those insulin at a very low price are mostly in Metro Manila. They had say, yeah, like yesterday somebody messaged me because she's from Bulacan and they had to travel to Manila just to buy the insulin. They should I mean I said they should add more hospitals that are accredited to distribute this insulin outside Metro Manila. It's really sad, if you see members that are, dying, getting worse because they cannot afford. Now, number four is creation of what we call diabetes centers in the rural, or not really, local government level. Like, just for example, like Pasig City, they have this diabetic centers. I think they have a seminar every Wednesday. They just use a multi-purpose space where you know uh, that they can use. They have different schedules every day for different type of health problems, and it is just for awareness, education about diabetes. Because until now, I still see people have uh, what you call certain beliefs that actually are being debunked by a lot of research done about the disease. And this is also why the Philippine Diabetes Support Group was created, because we noticed that there are very few resource person uh, that are that you can ask. Like, I would like to thank, our group is now more than 21,000 members, Filipinos. About 99%, I think, are Filipinos all over the world. Now, we would like to thank all the doctors, nurses, diabetes educators, um, nutritionists, and dietitians that help uh, uh, teach or debunk the old belief about the cure or about the disease itself. And there are also some what do you call this? Some companies like pharmacies, pharmaceutical companies, hospitals. They In our group, what they do is they hold an online seminar, how to teach, how to prevent, how to maintain, how to uh, manage diabetes. And there are some hospitals like the one that I attended was in UERM. They have this sort of activity like a free screening of diabetes. So a lot of people went there just to know if they have it or not. And they have this 100 peso consultation and education every week. I think it's every Thursday of the month of the week. Now, things like this can teach people to be aware that diabetes can be avoided just by knowing what's not good or what is good. Because most of this is just lifestyle change or the food that they eat. And lastly, promotion of healthy lifestyle. Uh, One example is encouraging food establishments, to create healthy food options. Uh, Sometimes you can give incentives to this kind of companies. Right now, the ones offering this healthy food are specialty stores, specialty shops that the prices are so high, but most of these are just vegetables. So uh, that's as of now, yeah, that's the most of the things that we have been discussing in our group, complaining and everything. So I hope our health DOH or whatever can help, and a lot of organizations are willing to help too. So it's just that they need support. Thank you.
Thank you. Thank you, ma'am. That's indeed very good points that you raised, and I really see, from your stories just how important these changes to our healthcare policies are. So next up, I'm heard naman, no? Okay, that's good. Okay. Next up, we have our next reactor is Mr. Joseph de Guzman, the Executive Director of the Psoriasis Philippines, Chairman of the World Psoriasis Day Steering Committee, and member of International Federation of Psoriasis Associations Executive Board. With his extensive experience as a health advocate, Mr. de Guzman will share with us his thoughts on today's discussion and his insights through a patient's perspective. Mr. de Guzman, good morning. Good morning po.
Good morning, and thank you very much for the invitation. I think I'm going to probably stay on 2 points, the current gaps particularly, and the need for a patient-centered healthcare system. In terms of the current gaps in healthcare system, my observation was I think the problem that our healthcare system emanates from a very fragmented structure with a long history of unfair and unequal access to health services that significantly affects the poor. The government needs to create a program that will cut the high cost of high out-of-pocket costs or spending of patients that further widens the gap between the rich and the poor. With no permanent standard guidelines properly explained to the population, our public healthcare system is like a labyrinth that is difficult, if not impossible, to navigate for ordinary people. This scenario pushes the patients to go to private healthcare providers that challenges their meager resources. The shortage of human medical resources, especially doctors, slows down our healthcare system that makes the service delivery less efficient. Case in point, there are only around 200 rheumatologists in the Philippines. With a population of over 111 million, these 200 doctors serves 30% of our community afflicted with psoriatic arthritis, which would give you a ratio of around 1 doctor per 3,000 patients with psoriatic arthritis. Now, if we include other patients with lupus, ankylosing spondylitis, arthritis, scleroderma, and the elderly sector of our society needing care from rheumatologists in the equation, it will push us away from the ideal doctor-to-patient ratio prescribed by the WHO, which is 1 doctor per 1,000 patients. The presence of trust in the healthcare, in the health system, which necessitates a clear, well-studied and well-implemented national policy, must stay transparent while respecting and protecting the privacy and rights of every patient. All these were made even worse by the pandemic. I have not seen so many doctors getting frustrated, frightened, and exhausted, both physically and emotionally. Most patients like me were not trained in medical schools like doctors, but we are experts in our conditions and we live with our disease 24/7. Our initial consultations with our doctors, initially diagnosis, usually comes from the physician's perception and theory on what they think, and what they see is just the tip of the iceberg. But we as patients and our families know and experience what is underneath that iceberg. Our first-hand experience could bring an improved understanding and appreciation of our disease. For optimum and more inclusive care to be achieved, we need to consider both the lived experience of patients and the healthcare expertise. We need to adopt people-centered healthcare that includes everyone who belongs to the whole spectrum of care, and each plays a crucial role in shaping the health policies. As patients and families, we would not be reduced. We should not be reduced to or defined by our disease, illness, or condition. We are people with individual preferences, needs, and abilities who must be present and active in shaping the policies and services with an equal voice as others, without hierarchy among those involved in crafting the health policies. We are people with dignity and not mere cases. Thank you very much.
Oh, thank you, Mr. De Guzman. And also, we appreciate how you so eloquently delivered your message on those two very strong points. Next up po, we have our next reactor naman po, with her extensive background in working with patient groups, Ms. Carmen Auste, the CEO of Cancer Warriors Foundation, who is also the Vice President of the Cancer Coalition of the Philippines and a member of the newly formed National Integrated Cancer Control Council. Without further ado, let's welcome Ms. Auste for her reactions on today's presentations.
Thank you very much, Paco, and thank you very much for all the previous speakers and reactors for your very inspiring and for some enlightening inputs. Maganda po yung medyo nasa huli tayo kasi nabanggit na po yung pinakamahalaga. It is widely recognized that patients, their families, and the communities they belong to are the most undervalued resource in the healthcare community. Most often, hindi po nakikita ang kahalagahan ng mga pasyente, ng kanilang pamilya, at ng mga pamayanan kung saan sila ay mga miyembro. Sec. Jimmy spoke of the urgent need to engage and assist communities, especially the marginalized, those in geographically inaccessible areas, as part of whole of society and whole system strategy. Si Girlie naman po, ipinailalan niya sa atin ang kahalagahan of engaging and empowering patients and patient support groups in all levels of care and policy making. So we agree with all of those inputs. I would like to focus and share with you 7 keywords that for me and for us in Cancer Coalition encapsulates the essence of person and people-centered as well as family-centered care from the perspective of both patients and their families. Ang una pong salita I heard or pinakikinggan, at si Eileen at si Joseph po has already clearly shared why this is necessary and vital to ensuring that health policies, programs, initiatives are informed and shaped by the voices, ideas, and lived experiences ng mga pasyente, kanilang pamilya, at ng mga pamayanan. The second important word for us is valued, pinahahalagahan. Recognizing that patients and their families are partners in care, not just helpless beneficiaries or visitors or visitors, sabi pa nga ng iba. As Joseph has said, we are more than our disease. Ang pangatlo po ay respected, iginagalang, hindi binubulyawan, hindi iniinsulto, hindi binabaliwala, hindi pinagagalitan na parang bata. Supported, tinutulungan at ginagabayan, and this has to do with holistic quality care and patient safety throughout the whole continuum of care for all diseases and all patients of all ages and stages. And this goes all the way from preventive, promotive education, all the way to diagnosis, treatment, rehabilitation, reintegration, or bereavement in the case of those who lose their loved ones. Ang susunod pong salita ay protected. Ng mga pasyente ay kailangang mabigyan natin ng proteksyon at kung kinakailangan ay ipagtanggol ang mga karapatan nila na may mga pagkakataon na hindi napibigyang halaga. And in this context, yung ating pong healthcare workers, para po maproteksyonan at mapangalagaan nilang pasyente, kailangan po proteksyonan at pangalagaan din natin sila. Nung nag-uumpisa pa lang po ang COVID, napansin po namin yung mga nasa oncology offices po, hindi po binibigyan ng PPE and other protective equipment. Kasi at that time po, they were not considered as frontline workers. But we felt for our patients to be protected, we need to protect them. So tumulong po kami na magkaroon sila ng kung ano man ang kailangan nila para magampanan nila ang kanilang kailangan gawin at the same time ma-protectionan po sila. So ito pong protected ay for all of us, for all the stakeholders in the healthcare ecosystems. At panghuli, enabled and engaged, na pinapahusay po natin ang mga abilidad at kabahagi po sila ng ating mga usapan at pagkilos. Katulad po nito, nagpapasalamat po kami sa mga organizers na yung mga boses at mga karanasan at pangangailangan po ng mga patient groups ay inyong binigyan ng pagkakataon na mapakinggan dito. And finally, as part of future-proofing our healthcare system, so it's not only person and family-centered, but as well, it becomes resilient as well. I'd like to share and leave behind two messages and quotations. Because sabi nila, para po mangyari yung 7 salitang sinasabi natin in terms of patients, families, and communities being heard, valued, respected, supported, protected, enabled, and engaged, kailangan to meron tayong champions for change. And we hope that everyone here and all those that will be listening to the reruns will be those. Each of us is put here in this time and space to personally help decide the future of humankind. Paliitin na lang po natin the future ng bayan natin, ng ating healthcare system. And finally, let us not be constrained by our history o yung mga masasama at malungkot na nangyari sa ating buhay bilang mga pasyente or bilang advocates. Let us live out our imagination and aspiration. So we invite everyone and we commit the Cancer Coalition, Cancer Warriors will be with you as we move toward together in terms of imagining a better, more people-centered, more supportive, responsive healthcare system for all our patients of all ages everywhere. Doon na lamang po at maraming salamat.
Thank you, Ma'am Auste. That was a very comprehensive reaction po, and thank you po for that. Next po, our next reactor is Dr. Johnny Lokin, the president of the Stroke Society of the Philippines. Dr. Lokin is, as a clinician and representative of the society, will share his perspectives on what is really a responsive healthcare system for frontline health workers and patients with non-communicable diseases at this time of pandemic. Dr. Johnny?
Yeah.
The floor is yours, po.
Yep. First of all, on behalf of the Stroke Society of the Philippines, we are thankful and honored to be invited to this forum on synergy towards a people-centered health agenda by the ADRi Institute. As Dr. Hara pointed out, presented the data on the leading causes of death last year, we saw that cerebrovascular diseases or stroke was actually ranked third in 2020, behind heart disease and cancer. Likewise, if you listen to Dr. Galvestan's talk a while ago, he also emphasized on non-communicable diseases, placing vascular diseases on the forefront of the priority health agenda, which actually sets the tone for my brief reaction. So if we look at UHC, Universal Healthcare, or Health for All, it still remains the banner healthcare agenda of our government, and of course, with the passage of the Act last 2019, no, it sort of catapulted, no, the notion of universal healthcare among Filipinos. Now, the Act actually, we know, intends to broaden healthcare access and provide comprehensive quality services without, ideally causing financial hardships, no, to the nation, to the Filipinos. No? And under the AOHC framework, the Stroke Society was, well, sort of fortunate that the Secretary of Health signed the administrative order, no? DOH AO number 2020-59, which is also called the National Policy Framework on the Prevention, Control, Management, and of Acute Stroke in the Philippines. Now, we have been working on this from the start of the year, but unfortunately, the AO now is undergoing review, no, within the DOH, no, as we have just recently received a communication from the department. Well, the National Stroke Policy recognizes the need to address the growing burden of stroke, no, particularly to, of course, the patients, the family, and the healthcare system at large. We know that, at any given time, stroke is always ranked either second or third as a leading cause of death in the Philippines and the primary cause of disability. Now, the financial impact and economic burden of stroke, we know, can be staggering because, as most of our colleagues have mentioned, no, the majority of the cost of treatment usually are borne out of pocket. So stroke is also like that. No? And of course, the disease can be catastrophic, which may lead to disability and death. And of course, the affected households are always pushed to the brink of financial collapse, now considering the cost of treatment, the cost of care, rehabilitation, and the loss of potential income, particularly when these stroke survivors or victims are the breadwinners of the family. So we therefore look at there should be a development, no, in terms of infrastructure for stroke care. No? So while the burden is significant, well, what we know for now is that acute ischemic stroke is treatable, and early identification of the signs, okay, rapid emergency response, and immediate access to treatment in a stroke-ready facility, as we would like to call it, can significantly reduce the risk, no, for death and increases the chance, no, of recovery of these patients who suffer from stroke. So we have a saying that time is brain, which emphasizes the need for immediate response to minimize brain damage, no, and reduces the risk of permanent disability and lowers mortality. And of course, we expect that outcomes of these patients can be improved when there is timely intervention. Now, we know that based on data in the country, in the Philippines, we only have 49 stroke-ready hospitals that serve our 110 million population. And 23 of them are in the metropolitan Manila area, while the remaining 26 are spread out, no, in Luzon, Visayas, and Mindanao. Another issue will be the availability of diagnostic equipment, which is important, no, in the stroke pathway that we establish, no, that ensures that there is immediate and complete diagnosis of what type of stroke we are dealing with. However, similar to hospitals, there is an uneven distribution of diagnostics nationwide, thereby prolonging again the time to diagnose these cases and to provide treatment. So this situation calls actually for increased investments in the capital outlay for infrastructure development and equipment, such as CT scans, okay, at the minimum, and trained staff to attend urgently to attend to stroke patients. Now, one other aspect from our part, no, would be the financing of stroke. No? So we know that financial burden of health services is a primary deterrent for timely treatment and management of stroke cases. And aligned with the goals of the universal healthcare, I think it is imperative, it is important to improve the financial risk protection for stroke patients. And again, we probably will again have to look at the PHIC, or the National Health Insurance Program. Now, from a patient's perspective, optimizing financing can include review and enhancement of the existing payment schemes, no, of benefit packages. Right now, the packages that we have would be for ischemic stroke. It's 28,000. For a hemorrhagic stroke, it's 38,000. So we'd like to probably, present to the PHIC or propose a better package for our stroke patients, stroke victims, to ensure that these are responsive to the needs of the patient throughout the stroke care continuum. Likewise, the financial support can cover non-health related costs of care, like, for example, transportation. So from a healthcare system perspective, funds should also be allocated to improve system level components of stroke care, as well as prevention programs and interventions, which are actually part of the provisions that are contained in the National Stroke Policy. So for this meeting, for this forum, I think the theme is indeed very timely. And looking at the burden of stroke to the patients and their families, we agree that a people-centered health agenda would pave the way for, whole of government approach to improving stroke care in the Philippines. As it captured in the National Stroke Policy, investments in prevention, service delivery, infrastructure, financing for stroke will indeed, if it will be implemented, it will be a milestone for Filipino patients across the country who suffer from stroke or who are victims of stroke. And we hope that this administrative order hopefully would have a positive review with the DOH, and hopefully it will be implemented. So again, thank you for this kind invitation, and have a good day, everyone.
Thank you, Dr. Lokin. Thank you, po. At this point, we come to our last reactor for the second part of our program. And our last reactor is none other than Professor Zenaida Velasco, who is an experienced nutritionist, dietitian, psychologist, and educator, who is currently the national president of the Nutritionists Dietitians Association of the Philippines. Professor Velasco will be sharing her insights on today's presentation and how better nutrition can be part of a responsive healthcare system. Dr. Velasco? Yes, ma'am. Our last reactor for today.
Good morning, and thank you for the organizers of this event. We'd also like to thank our distinguished speakers and panel of reactors. Malnutrition is a threat multiplier. If we do not take action today, then we would not be able to protect the vulnerable populations from malnutrition from the effects of COVID-19. Let me walk you through some principles and concepts in malnutrition. Malnutrition is not merely a health or a social problem, but indeed it is a development problem. Therefore, it is linked to poverty, illiteracy, inequality, deprivation, and certain environmental factors. Now, being a developmental problem, we can eliminate malnutrition by nutrition-oriented and nutrition-sensitive development strategies and approaches. This can be planned and implemented with the active participation of the people, as mentioned by Dr. Jaime Galveston on the bottom-up approach. Indeed, malnutrition can only be solved through our collaboration, the integrated and coordinated efforts of the public and private sectors, international agencies, civil societies, political leaders, and we also have to consider the people at risk. Looking at the model of nutrition and underdevelopment, low income would mean lack of food intake, lack of food supply, low food intake, and if there's low food intake, this could really lead to malnutrition, especially among children who are vulnerable to disease, and eventually before they reach the age of 5, they may also die. Once the child gets into school, because of stunting, which is again another effect of undernutrition, it may lead to school dropout, low education and poor skills, and therefore it is difficult to find a job, or it could also lead to underemployment. To society, it would also mean low food production. Talking about the cycle of nutrition for pregnant women, and this is very important. Women with low weight gain in pregnancy will have low birth weight infants, and a low birth weight infant will have bouts of infection, frequent illness, coupled by the low food intake. This will lead to poor growth and development, which we now call stunting or wasting. When the child grows to be an adolescent, there will be an adequate growth spurt. And when he reaches adulthood, certainly we expect that this person will be short and underweight. And when the time comes that the adolescent teenager becomes pregnant, it will now pose maternal nutrition problems. So we're only looking at a framework as proposed to us by Black. And therefore, in order to look at how we may be able to protect the health of the fetus and the child, we are looking at nutrition sensitive and nutrition specific mechanisms. But we also have to look at the enabling mechanism or the enabling environment. And this will involve knowledge and evidence, politics, leadership, social, economic, etc. So it is important, and the secret sauce, so that we may be able to prevent chronic diseases, prevent malnutrition, is to look into the first 1,000 days. It is a window of opportunity wherein we could also promote physical, mental, and emotional well-being. The people-centered approach can really improve nutritional status. And when you improve nutritional status, it will result to better health outcomes through a responsive healthcare. So when you talk about people-centric approach, we always have to pay attention to the people first, because if we do, this could lead to quality of life, and our people would be feeling more valued. They will have the internal motivation. They will find meaning and purpose in life, and it will really promote a better engagement with the healthcare professional. In helping out this person create good health choices, we are also empowering this person to take control of his life. If this person has control in his life, then we could say that this person can eventually be happy and healthy. But the support really of the person will come from the synergy of everyone. And I believe together, everyone accomplishes more. Thank you very much, and good day.
Professor Velasco, I think that was a great way to close out our panel of reactors this morning. So thank you po, Professor Velasco, and thank you to all of our reactors who shared their insights this morning with us. At this point, I would now like to open the open forum, the question and answer portion of our program, seeing that it is 11:07. So we're a bit behind schedule. Yeah, but I think we can entertain a few questions. And I think a good place to start would be here in the Q&A section. We have one question here in particular, which I will be reading out, and I hope that a few of our speakers and panelists would like to weigh in. One was actually already answered, but I think it's interesting enough that I should raise it again. This is a question from Louis Montemar of Bantay BK3. And I think he's one of the members also and supporters of UHC Watch. And his question is, for any of the speakers, the data on kinds of diseases prevalent in the country seem to suggest that we still have much of disease of the poor. Sorry, let me repeat that now. The data on kinds of diseases prevalent in the country seem to suggest we still have much of the diseases of the poor. Imagine, we still have indecences, oh my God, sorry about that. Occurrences of tuberculosis. These are diseases that can in fact be avoided with good nutrition and diet. The link with food security concerns is really strong. A comprehensive health agenda should dovetail with our agenda on food security for our ordinary consumers. What are your thoughts on this? So what I think Professor Montemar is asking is, what are your thoughts on dovetailing our health agenda with a food security agenda as well. Any of our speakers are free to answer the question.
Well, definitely, yes. We are seeing this overlap between the older, in quotation marks, infectious diseases, which tends to be more of poverty or overcrowding or communicable diseases, now overlapping with the non-communicable diseases, primarily led by cardiovascular and cancers. In fact, if you look at the top 10 causes of death, I mean, like basically you can lump cerebrovascular disease, ischemic heart disease, and hypertension all together because they're basically the same pathology. Yes, I'm a cardiologist by training, so I look at that in the same light. So there's really this significant overlap. We're in this phase, and it really is a huge burden upon the healthcare system of our country. And we should be gearing all our efforts towards addressing these conditions. Now, definitely food and food security is a major issue. I'm not competent to talk about that, but we are very import dependent. Our country is very import dependent. And that for me in itself is already something we should be very concerned about. I don't know what the proper forum is for this, but that's something definitely that should be discussed quite aggressively.
Thanks, Dr. Weaver. Does anybody else want to weigh in on?
I would agree. I would agree with what Dr. Tames said, because if you see, health will not be far away from the kind of economy that we have. So most of our people are still very poor. As was said, we are import dependent. We're supposed to be an agricultural country, but we don't have food security. And of course, the ones who will be most affected with malnutrition will be the children, will be the young ones, as was mentioned. So these infectious and also these diseases caused by poverty would be with us as long as we are not able to solve this.
Thanks, Dr. Hammond. Yeah po, sige po. Ma'am Carmen.
While I agree with the question with Dr. Beaver and Dr. Lenny in terms of poverty exacerbating or making worse the nutritional status of not just patients, but of everyone, the reality also is that a number of those in our healthcare system right now have not yet fully accepted nor recognized that there is a link between nutritional status, the type of food and diet that the patients have, and patient health outcomes. So I'm very glad that we have here the Nutritionists and Dietitians Association, because that is an advocacy that we would like to be able to start on. Greater recognition. It is already happening all over the world. In terms of cancer, for example, if you're a child with cancer, if you have poor nutritional status, then your survivorship and your risk for death is higher than if you had a good nutritional status. And most definitely, this calls for that link between our agricultural and health policies, but as well that very important element of nutrition and diet, which most often is forgotten and not given the importance it deserves.
Okay, thank you po. Does anybody else want to weigh in on that question? Okay, in that case, I'll just move on to another. We do have several. So we actually have several interesting ones here. But I wanted to ask this one. In particular, it's about fixed copay arrangement. So the question is, the no copay or fixed copay, even in non-basic accommodations, is just that, theoretical. It never happens in real life. So why are you so afraid of this policy that is long overdue? The intent is so that patients do not enter the hospital with a blank check. There is no predictability of costs, so this policy is important. People need to prepare and not be subjected to bill shock, which is the situation now. I realize it's more of a comment, but if anybody would also like to respond to this issue of copay.
Paco.
Yes, po. Dr. Almora.
Yeah, I think that refers to my presentation.
Yes, po.
The copay is a promise made by the government that they are going to, that there is no copay. And unfortunately, that we have two health service provider, the government and the private. So the government makes a promise to the people to give no copay, meaning they are willing to be the one to pay when there is an excess in the provided case rate, because obviously the PhilHealth cannot afford to pay in full the all that it is needed for the management of the patients. And if the patient is in the private hospital, it would be unfair if the government who made the promise will not be the one to reimburse. So this does not refer to the patient paying the copay, but it should be the government that should be paying for the patient, because it is the government that made the promise. I understand very well. I listened to the presentation of the reaction of Ma'am Eileen Antolin, and I fully agree with her that the way we manage patient is not anymore managing the patient, but we are going to manage the policies, we are going to manage the law. So we can become detached to the needs of the patient because precisely of the so many limitations that is being given us through the law and the policies. Now, there is nobody nearer to the patient. We touch the skin of the patient, the doctors, the nurses, with the facilities of the hospitals. We know what is best for the patient. And we are the ones that are really concerned about their getting better. But then our fear is that we will not be managing the patient anymore, but we will be managing the demands of the third-party payer. It is not the patient that's going to be followed. It's not the doctor that's going to be followed, but the actuarial of the third-party fund manager. Remember, it's not PhilHealth that's paying. They are only managing the fund. It is the patient himself, the people of the Philippines, that's providing that money. And therefore, the patient should be the one to be followed. So that is our fear, that our relationship with the patient, our contact, our concern for the welfare of the patient will be overshadowed by the financial realities of the fund manager who will be dictating the terms of management. Thank you.
Thanks, Dr. Almora. I didn't realize that question was directly directed to you during your presentations. Thank you for responding appropriately. Our next question po is from Mr. Obit Pagdanganan po, no, in the Q&A section. And he asks, what is being done to reduce the very high out-of-pocket expenses in the Philippines, which remains as the highest in Southeast Asia? 54% of the 799 billion in 2018. Would anybody like to share their thoughts on that, respond on the high out-of-pocket expenses in the Philippines?
The government must have skin in the game. They have to pay for the drugs of the patient, and it should not be charged to the patient. It's not a matter of high prices in the Philippines. If you look at the generics markets, be it Indonesia, be it Philippines, highly genericized markets, it's only really Thailand that actually has a reverse ratio where the government accounts for like 70–80% of healthcare costs and the patient only pays 20%. Now, these are generics. Yet why is Thailand, the ratio of the out-of-pocket so small? The government is paying for it. Here we have the reverse scenario where the government will force down prices, mandate it, despite the fact that generics are more than 75% of the market, and yet expect the patient to be able to pay for all of this. It is skin in the game. It is the government actually paying for the drugs, distributing it properly, and making sure it gets into the pockets of the patient, rather than all this wastage that we keep hearing about.
Yeah. Yeah, we have several people who want to. So I think Ma'am Madaraog, you were raising your hand, if I was correct.
Yes, for our sector, payment by the patient is really out of the question because their disease is rare. It is lifelong. Their medicines are needed weekly, and for as long as they're still alive. The cure that will possibly a one-time cure would be gene therapy. Okay, although this is going to be take a long time. It's now being started in the United States, but by the time it comes to the Philippines, I think that will be about 5 to 10 years from now. Now, the available treatment is either specialized medical food or enzyme replacement therapy. And for medical food, that is about 30,000 a month for a family that's earning 25,000 a month. That's our average income of our registry. And for the enzyme replacement therapy, depending on the weight, it's 80,000 per vial, and some require 25 vials twice a week. Okay, so that's millions of pesos. So there's no way that we can co-pay unless you are the top 10% or top 10% of the people in the Philippines. So I think for our sector, one is that we have to implement the law that the syntax is the source of funding. Whether pandemic or not, there are collections for syntax. It's been 5 years that we have been appealing for the Department of Health. In fact, in 2019, we already had a budget of 54 million, but eventually it was given to a bigger disease group. No? So they look at in spending their budget, which has the bigger population. And in my opinion, if this is not funded, then we will not be part of the universal health care.
Thank you, ma'am. And do you think po, while I have you po, Ma'am Madraog, and you think that the implementation of the Rare Disease Act can help with patients living with rare diseases as well?
Well, it's been 5 years and we've been appealing 5 years with the Department of Health. And tagal ang process for them to decide. We're competing with so many treatments. So for each treatment, it requires an administrative order, which has been for 2 years already. I don't know if it has been already done, strategic planning, and then public consultation. And now we have the HTA. HTA alone will take 2.5 years per treatment. And, when they'll only open in March, and there will be a floodgate of nominations. So really, right now, our goal is not to save lives, but to improve the quality of life where at whatever stage it was identified. No? So I think we really need, and seeing the available corruption, where these are billions of pesos. So how can't they not even give it to people who really need help?
Yes. Yeah, it's frustrating to say the least. Po. I think po we also have Ma'am Antolin, who's been raising her hand since kanina pa. So I think I should give her an opportunity.
Opinion ko lang po. Mahirap naman kasi ang nangyayari, parang ang gobyerno ang nagmamanage ng pondo ng mamamayan according to how they perceive the system should work, na hindi naman talaga realistic yung estimates na ginagawa. Kagaya for example sa breast cancer, where ang benefit package for breast cancer sa lifetime ng isang tao is 100,000. Alam naman natin sa surgery pa lang kulang yung 100,000, and meron pang chemotherapy, meron pang radiation therapy, and hormone therapies habang nabubuhay pa sila. So ang nakakalungkot, ito realidad hindi lang bilang nagre-represent ng boses ng isang mahirap na pasyente, bilang isang nagbabayad din ng premium ng PhilHealth, na bakit ang gobyerno ang nagdidikta ng kung ano lang ang dapat na halaga na ibibigay sa bawat sakit ng isang pasyente, tapos ang magbabayad ay ang mamamayang Pilipino, and then i-empower ng gobyerno ang mga hindi nagbabayad na kunin ang benepisyo samantalang hindi naman sila nagbabayad. Hindi ko po sinasabi na na dapat hindi natin tulungan ng ating mahihirap. Pero meron pong inequality. Parang pinupuwersa ng gobyerno ang mga nagbabayad ng PhilHealth para akuin ang responsibilidad ng mahihirap na dapat sana responsibilidad nila. Malungkot din pong isipin na habang alam naman natin na maaring masamantala yung mga benepisyong ito dahil hindi naman po talaga natin, alam naman natin na hindi foolproof yung mga polisiyang na nakikreate. At aware din tayo na meron pong mga nangyayaring maliliit na paraan ng pagnanakaw sa loob ng sistema ng gobyerno sa paraan ng pag-i-implement ng universal ng PhilHealth law. So sana magkaroon po ng realistic na allocation nung budgeting, yung tamang allocation ng mga costing ng mga cases na inilalagay sa ating PhilHealth package. At akuin ng gobyerno, dapat na po talagang lagyan ng pondo ng gobyerno ang kalusugan. Mawawalan po ng saysay ang lahat ng polisiya pinag-uusapan natin kung hindi po nila lalagyan ng pondo yung DOH, yung mga polisiyang ginagawa.
All right. Thanks, Ma'am Antolin. And at this point, given the time as well, I think I want to just end with this one last question we have, and I hope to give everybody the opportunity to weigh in as well. So if everybody can also, try to keep the answers tight. But the main question kasi po dito, given all of these challenges we've discussed, given especially the elections coming up, and the situation, the public health situation we're in now, if you are given two main points to be included in the next health agenda, what will you prioritize to realize universal health care and, of course, reduce out-of-pocket expenses? So just 2 points. Like, what are the two things that you think you would want to see in the next health agenda? If I could start with, in the order of our speakers, Dr. Lenny Hara, if you could, please, ma'am.
Okay. I would like to see that this government put money for the people's health. So that's it. And stop this corruption that is happening around us. And I would like to have leaders that will see to it that this can be done, because, we are paying taxes. Our health budget has been decreasing. So we can increase the health budget and then look after the people who would need this. That's it.
Thank you, Dr. Hara. Miss Gurley?
Hi. Yes, two things.
Two things.
Yeah, put more budget into health, make it a priority, and be accountable for the funds that will be put in the health budget. Thank you.
Thank you, Ma'am Gurley. The great points. Dr. Beaver.
We need accountable leadership, accountable for their actions, accountable for delivering on the promises, and accountable for fulfilling the acts of the laws that are in place, properly funded, of course. And I think if we can elect the right leaders, that's really, I think, the way to do it.
Indeed, Dr. Beaver. Sige po, how about Dr. Jaime Almora? Kayo naman, sir. Two things po that you would like to see the next agenda.
I would like to talk of three things.
Three things, sige, sir.
There are actually three things that need to be complied.
I'm sure more than three pa, pero sige, sir, go ahead.
Healthcare delivery system. We have accessibility, affordability, and quality of care. Okay, if we talk of accessibility, it's the physical availability of providers. So there has to be enough hospital, has enough manpower. But also accessibility is being able to afford the healthcare. And affordability, the second one, is not a function of price, as Dr. Tamesis is saying. Affordability is a function of purchasing power of the client. But in this case, since the government wants to come in to fund it, then it depends on the purchasing ability of the government. So we want people to access healthcare, and the best way to do that is to prevent health hospitals and facilities from dying. You know, if you subject them to too much threat for their survival. As it is now, many hospitals have closed already.
Yes po.
From a count of 1,987, we are down to 1,430. So the hospitals are dying because of the pandemic, but not pandemic because of the failure of PhilHealth to pay as well, and the manpower problem. So affordability, as I said, is a function of purchasing power. So the government should come in to substitute for that, for those sector of the society who do not have that purchasing power. So we have two systems of delivery of healthcare, the government system and the private system. It is in the government system that should provide the affordability and the accessibility. The private sector is necessary for the quality, because it is the survival of the private sector. The main survival is through delivering quality care because of the competition. They cannot compete if they are not profitable. So they have to be profitable to be competitive and to be able to be at the cutting edge of technology and deliver the quality. So if you are looking for, you should go to the private hospital. Okay, so the government should be mindful of that to really differentiate which of those sectors that needs the help of the government and those sectors that do not need the help of the government. Thank you.
Thank you, sir. Thank you. Of course, we also want to hear from our reactors. You've shared your time with us and your voices are valuable. Miss Ma'am Antolin, if you have two points that you want in our health agenda.
Isa lang ang point ko. Maglagay ng qualified na mga tao na mamamahala sa sektor ng kalusugan. Yun lang po ang mahalaga doon. Hindi po militaristic approach, hindi po general ang kailangan natin. Kailangan natin ng mga siyentipiko at saka mga dalubhasa.
Thank you. Great point, Ma'am Antolin. And Ma'am Madaraog, kayo naman po. Your 2 points.
My 2 points, maybe they also strengthen PhilHealth, no? Because PhilHealth makes the Z benefit, okay? And they have to be funded well too by the government.
Thank you. Okay, Ma'am Dunce, do you want to share your key point or two for our health agenda that you want to see?
Actually, the only 2 things I would like to say is that, you know, the present projects are being implemented.
Yes, po.
As the previous wishful thinkers have mentioned that, you know, the in charge should be health expert. You know, who knows what he is doing. That's it. Thank you.
Yes. Okay. So leadership, we need leadership and the implementation, the real implementation of projects. That's what Ms. Dutz has said. How about Mr. Joseph de Guzman? Sir, did you want to share also?
Yeah, probably just a qualified head of the Ministry of Ministry of Health, you know, and probably a health system that would really care for patients and would listen to our journeys, to what we bring on the table, respecting our rights and privacy as well. Thank you.
Thank you. Thank you, Mr. De Guzman. Something that I think Filipinos deserve, yes. How about Ms. Carmen Auste, ma'am? Ma'am Auste, I saw you chat, pero baka you want to share.
I agree with all the ideas that have been proposed. I think a very important thing as well, my first point would be there were many valuable ideas here. If we can really put it together into a framework agenda that we both bring to a legislator and the presidentiables, so that it is something that in effect becomes a guiding document for them as they take over. Secondly, in terms of decreasing out-of-patient costs, 2 points, we know that there's money outside in terms of ADRi, funds from international development partners, regional and international philanthropic institutions, this can actually be tapped by our government in order to add to the funds that we have for health. But the more important one is for us to strengthen public-private partnerships. PHAP is here. I know that they have always expressed their desire to work with government to ensure better availability access to quality, affordable drugs. I think that's a discussion that needs to be further pushed, perhaps with the help even if legislators, if the ministry itself is not open to it, because one of the major costs of outpatient cost is actually related to medicines.
Yes. Thanks, Ma'am Auste. Yeah, that's a great point on the need for that broadly supported agenda as we move towards 2022. And I think UHC Watch, CCPH, and all the groups here would be all for that. Next up, Dr. Johnny Lokin. Kayo, sir?
Yeah.
Do you have any?
Well, I think all the speakers, weighed in on the salient points for, how what we want from the government. From the stroke society perspective, from the stroke perspective, as a private advocacy group, actually we are moving forward with our agenda, but we really need, the strong support from the government. So my 2 points probably is, if you are listening to the budget deliberations now, I think the budget of the DOH has been drastically cut. Okay, and probably my prayer is that while they are deliberating, we can probably have some budget for the non-communicable diseases in the DOH budget that will be passed, and of course more balance in terms of allocation of budget for both COVID related purchases and non-COVID related purchases, because I think there's really everything is really geared towards trying to provide the best care that the government can probably offer for COVID related responses. Then of course number 2 is just like the frustration of Ma'am Cynthia Madaraog, we already have a good administrative order that only needs to be implemented. And when I heard her say that it may take 3 to 5 years, my God, I think that would probably be what I would have to pray for, the operationalization of the national stroke policy with the proper budget coming from the Department of Health and from, of course, from the national government. Thank you.
Thanks, Dr. Lokin. Last but not least, we want to hear from Professor Velasco.
Thank
Your
you.
2 points, sir, ma'am.
Yes. 1, access to safe and nutritious foods. Taasan po yung budget natin ng meal allowance sa mga hospitals. Nutrition is a good foundation para labanan yung sakit. So we are more on the promotive and preventive. Second po, meron po tayong Administrative Order 0033. Ito po yung nutrition care process na dapat po sundin sa private and public hospital. So yun lang po, 2 points, pero foundation natin for good health is good nutrition.
Thank you, Professor Velasco. Wow, I think that was a great way to end our open forum. All of our speakers and reactors raised amazing points and I hope that whichever group UHC Watch, when UHC Watch does put together their health agenda, that all of these perspectives are considered. With that, I would like to close our open forum for today and move us on to the closing remarks, which will be, of course, thank you to our speakers and reactors, but I would also like to close the open forum and now move on to the closing remarks by Mr. Orlando Oxales, the lead convener of Citizen Watch Philippines and a convener of UHC Watch. Mr. Oxales.
Thank you, Paco. Thank you. On behalf of the Alliance of Patient Groups and Health Advocates of Universal Healthcare Watch, we express our great gratitude to the Strat-based ADR Institute, the President, Professor Dindo, the Executive Director, Mr. Paco Pangalangan, and the whole ADRi team for hosting this most timely and forward-looking forum. We also thank our esteemed panel of speakers, reactors, for their instructive insights on how the whole of society should move forward in building a truly responsive and patient-centered universal healthcare ecosystem. In this Philippine context, USC Watch believes that a sustainable healthcare system needs good, credible leadership. Leadership that can cope with the highly mutating demands of our country. These demands stem from lack of resources and distrust in the health system. We need stronger institutional accountability and responsiveness to the health priority needs of the community. This means the DOH needs to be true to its mission of continually moving toward universal health access and quality care. This also means that the DOH as an institution is aware of the inequities and must continuously improve to overcome them and provide more care for underprivileged. It also needs to be responsive to shifting health priorities. Policymaking must have a more strategic perspective and plan that looks at longer-term health systems development. We must have strong, evidence-based policies that are insulated from political influence. We need to establish a high-level coordinating body or commission to harmonize, or if need be, even compel all agencies to support universal health care and improve health outcomes of the country. We need citizen participation. This is of utmost importance at all levels of decision-making in the health sector, from local health boards to national health agencies that are involved in tackling health. People must be given a chance to contribute, to be recognized, so that solutions will be grounded to what is really needed by communities. We must accelerate digital transformation in our healthcare ecosystem. Our health systems must harness the best technologies to empower our healthcare institutions with digital solutions that expands access to healthcare services and efficiencies, such as the pooled procurement of health technologies to maximize limited funding resources. Digital transformation of our health ecosystem will ensure transparency, efficiency, and accessibility. The government, in partnership with the private sector, should take advantage of all the best advances in technology to improve our health system. We need the promotion of primary health, health seeking, and health values to the community to sustain co-ownership of health. We need full implementation and funding of the universal healthcare law, particularly the provision on strengthening health promotion at the national and local levels. We need a review on how our taxes are being allocated to healthcare and consider new sources of funds for health promotion programs. We need an increase in resources to prevent and control non-communicable diseases. These NCDs include, of course, cancers, diabetes, hypertension, chronic heart and lung disease, and autoimmune diseases, and let us not forget rare diseases. As advocates, we must be relentless in clearly voicing out constructive feedback to policymakers and UHC implementers in government and private healthcare institutions. Today's session sounds like a long list, a long wish list, that is, but it really reflects how the Philippine health system has been far from ideal to begin with. We have known this even before COVID and became tragically evident during this pandemic. Again, it all starts from good and credible leadership. From there, organization, strategy, policy, and most especially credibility follows. We must make our leaders accountable for their action. In action, or even misdeeds. It is citizens who are the boss and not the other way around. As we are now about to enter a transitional phase in our democracy, we must remember the lessons of this crisis and choose our next leaders wisely. As advocates, our mission to ensure the implementation of UHC is a challenging requisite to our country's sustainable economic recovery. We must all work together to make universal healthcare a reality. Thank you, and everybody have a safe and healthy life ahead of us. Thank you.
Thank you, Mr. Rosales. Thank you to our speakers. Thank you to our reactors. Thank you to our participants. This video, a recording of this discussion, will be made available on our social media channels, on Facebook and on YouTube. So thank you again, everybody, and have a nice day.
Thank you. Thank you, everybody. Stay safe.
Salamat.
Salamat po.
Stay safe, everyone. Have a
Marami
good
pong
weekend.
salamat.
Maraming pong salamat. Thank you. Stay safe. Have a nice weekend.
Thank you po
Looking
sa
forward
opportunity.
to a next
Salamat.
series of conversation
Yes.
Yes. Tuloy natin to.
to build on
Thank
what
you.
we
Let's plan for
have,
the next
diba?
steps po. Let's
Uh,
plan for the next steps.
by the
Salamat
way,
po.
may part 2. We'll invite you. There's a part 2.
Gusto ko yung dokumento na talagang pwede mo nang iharap at ipangsampal.
Oo, ang dami nating sinabi dito. Oo,
Diba?
baka isang libro na to eh.
Powerhouse itong grupo mong to eh. So,
Oo, tuloy natin to. May part 2. May part 2. We'll invite everybody.
Okay, thank you. Thank you.
Thank you very much,
Have a good
everyone.
weekend. Be safe.
We'll be ending it now. Thank you.
Bye-bye.
Ending the call. Bye.